Good evening, everybody. And thank you for joining us for our panel discussion here. The idea behind this is to help everybody understand the things we need to do when it comes to reopening, and to look at one, the medical aspect, and also look at best plans. So let me ask that we start with a word of prayer. I'm trying to keep up with people as they still come in. Let's open with a word of prayer. God of mercy, we have been talking about this disease for a long time, it seems like, but it's really been only a blink of an eye. We ask that you help us see what is right in your time in each one of your churches, and allow us to use our knowledge and our caring and our understanding to truly follow what was set forth before us by our Savior Jesus Christ, and that is love thy neighbor. And let us remember that as we talk tonight about how we can go about opening our churches safely. It is in your Son's name that we pray. Amen.
Amen.
So let me introduce everybody. For those who don't know who all is here, I'm Ed Sackett. I'm the Disaster Recovery Coordinator for Mission Presbytery. And the amazing thing is that pandemics fall underneath the DPAC committee. So we're trying to help everybody understand what to do next. On our panel tonight is, let me start with the doctors. Dr. Larry Williams from MD Anderson. And he works in disease research, as I understand it, Larry. Dr. Lynette Watkins, who is with Baptist Hospital Systems in San Antonio. Then we have Phil Zamora from Madison Square Presbyterian Church, and he is on their reentry committee, and also the chair of their communications. And Jane Bassett, and I'm going to get this wrong, Jane. You're the executive administrator, I think.
Director of Operations and Administration.
Okay.
Yep.
For First Presbyterian Church in Austin. But first, I want us to open up with a friend, Manny Ruiz. And Manny is the president of Techstar Bank. And Manny is one of the people who have miraculously survived COVID. And not only just having COVID, but also was on ECMO. And Manny wants to share his story because he believes that's what he is supposed to be doing now. So Manny, I turn it over to you.
Thank you, Ed. First of all, I want to say thank you that you guys are praying about this decision, because as you know, in the corporate world, in the for-profit world, a lot of times praying about this doesn't come into play. It all becomes about dollars and cents. And I realize that, being a bank president and talking to other bank presidents, how that plays into that. But you know, this journey kind of started out with, you know, me being a part of this decision making with COVID, to open, to not to open, be strategic about employees, and do we have backup in employees and stuff of that nature. You know, if I'm being honest, I probably thought when this whole thing probably hit, I probably would get it, but I would bounce back pretty quick and not miss a beat, because there was just too much to do with the bank as president. And it's always a dialogue, right? I mean, I'm a trustee for the Baptist Health System, so COVID was always in part of a conversation. And Board of Regents for Baylor, you know, that's going to come up with students, things of that nature. I serve as the campaign treasurer for the mayor of San Antonio, and that comes up almost almost on a weekly basis. In fact, we talked about it today at the CEO luncheon. Things like, should we open up Brackenridge Park for Easter? And please keep that confidential, because that's a big decision, because people will be upset with that if we close it. And so those are things that he needs to think about or pray about. And so he seeks guidance for that. And so these are a lot of things that I was a party and still am a party to all these conversations. And little did I think that it was going to hit someone like me, who was really a workaholic, just doesn't go on vacation, never called in sick. And when I got it, I got it to where, it's been at least 2 months. It's only now that I'm able to, in fact, I'm at the bank right now. What I do is I work from 5:30 till about 9:30 at night, just so I don't expose myself to other employees of the bank. But, I have antibodies that are built up of that nature, but I just have to be really careful, because this whole journey kind of started around, I guess about December 31st, when I first got sick with this, and was in the restroom, passed out. My wife, went in there and saw me, took me to one of the Baptist emergency clinics. And next thing you know, they say, you've got double pneumonia. I'm in an ambulance. I'm going to the Baptist health system. And I'm like, what is going on here? This thing, it's just happening way too fast. This doesn't happen to me. So my journey started out of the Baptist health system. There I was on a ventilator, ended up being on a ventilator for about 2 days. And then they changed me over to another hospital, the Methodist hospital there in the medical center, because they had access to what was called ECMO. And from what I understand, once you're on ECMO, people that are in the medical profession, when they find out you're on ECMO, they go, oh, that's not good. Because it's like, after that, you've passed away, basically. And I ended up being on ECMO for about 3 days. And when I was talking to my pulmonologist, he had told my wife and I that there's several people that try to get on ECMO, but because they're just limited amount of ECMO machines and people that can actually operate such a specialized piece of machinery, that not everybody gets to get on it. So they actually have a committee to decide who gets on ECMO. So they only out of the hundreds of people that I guess try to get on there, they only end up taking about 20%. And of that 20% that actually get on it, only 50% survive. And so when you're on that 7th floor COVID/ICU unit in the hospital, and there's people in their 20s and 30s and 40s that have been in comas for months and ventilators for months, and you see people passing away right before your eyes on that floor, it becomes surreal. It becomes real pretty fast. And it's then where you really start to have a closeness to Jesus, our Lord and Savior. You're close, but you get really close. And if I'm being honest, throughout my whole life, you always tell people that when you go through your life, that it's important. At least I tell my employees and my friends, and when I give my testimony, that it's always important to put your faith first, your family second, and work and everything else can be third. And if you have that right order, things should be okay for you. But if I'm being honest, that's not the way I had things. That wasn't the order that I had. I was busy climbing the corporate ladder and doing all those things that a type A personality person, that people would come to me to get it done. And I'd be the one, for Baylor, for the hospital, for the bank, for the mayor. And all of a sudden to get sick like this, it came to a halt. I was basically just thinking that my life was going to be over, and I really hadn't served the Lord like I wanted to, which means that my job is to witness and disciple and tell people about the Word of God. And that's not really what I was focusing on in this latter part of my journey. I was still climbing that corporate ladder, trying to do things in my career path. And that came to a realization and really hit home as I was on that 7th floor, thinking that, my life was going to be over, when they're telling my wife that, why don't you get us a medical power of attorney now? You may want to start making arrangements, because things don't look good for your husband, and it gets pretty real pretty quick. But it's I was told when I was in the hospital, and this just tells you, and you know this, that our God is a God of miracles. I mean, when I say I was on the ventilator for 2 days, I mean, I was told, and my wife was prepared, that be looking at least 10 days. And that when I was on ECMO for 3 days, that to be prepared that it could be anywhere from 2 weeks on up, and that I'd probably be in the hospital for a month. And so for me to be 2 days on the ventilator, 3 days on ECMO, and then to be in the hospital for 2 weeks instead of a month or longer, that's a God. That is a miracle. I had the doctors tell me that. I had my pulmonologist tell me that. And you really realize, I mean, sometimes I find myself mad and then feeling sorry for myself, because everyone that was getting this, it seemed like they get it and they self-quarantine. And that's not what happened to me. And I was social distancing. I was wearing my mask. We're kind of introverts, so we don't go out. So how I got it, I couldn't tell you. I think I got it from one of the employees at the bank. We have a lot of young kids there that don't really quite put an emphasis on taking care of themselves during this COVID time. So that would be my guess. But we were very careful, my wife and I. So I couldn't even tell you how I got it. But the fact is I got it. And when I did, it hit me really, really hard. And so, when we're making these decisions, especially our church, I mean, I'm a deacon at First Baptist Church, and I'm a Sunday school director with my wife. And there's always a conversation about, let's make sure and get everyone into our classrooms on for Sunday school, and make sure everyone's there on Easter Sunday and what have you. And I just said, I'm not doing it, guys. I can't. I'm not ready yet. I don't feel comfortable yet. There's a lot of people that haven't been vaccinated. I'm not going to tell people you have to come to church. I think that's a decision that they're going to have to make as families and pray about it. But for me and my wife, in light of what I've been through, I'm just not going to do it yet. And so I can't say that has made everyone happy, but at the end of the day, that's between me and the Lord. And so that's something that I've told them that. And so it turns out also that it's during this journey of mine, I got to a point, because you kind of go through this COVID PTSD and all this anxiety. And I found myself getting really upset, if I'm being honest. And I'd say, why me? Why is this happening to me when everyone else kind of 10 days, self-quarantine, whatever, and they're not feeling that bad? How do I get hit so hard? And my wife would always put things in perspective and say, man, you've got to quit feeling sorry for yourself. God chose you to perform this miracle, and it is your job to share the story. And so don't focus on the negative parts of this disease, but focus on the positive stuff. And so that's what I've been doing. And then one of the things is I'll share with you that when I was in the hospital, I didn't come to find out till after I got out of the hospital that my brother, who's 2 years older than me, that he was at the hospital at Methodist Metropolitan while I was Methodist Medical Center. And they didn't really tell me just how he was, because they didn't want to worry me on top of what I was going through. But when I finally got home 2 weeks later, they told me he'd been on a ventilator for a month. And I knew then, when you're on a ventilator for a month or longer, that's not a good thing. And long story short on that, on January 31st, he passed away. So it could have been a story where both of us were in the hospital at the same time, and then both of us passed away in the same month. But by the grace of God, God's mercy and grace, he saved me. And I shared the story briefly with Lynette and Ed, and they said, well, we'd love it for you to share that story. And that was really kind of my story and commitment, was that I told God that I would always honor him and tell the story so that people would know about his grace and mercy.
Thank you, Manny. Really appreciate you telling this story, and my heart goes out to you for your brother and his family. And thank you so much for being willing to share your story with our people here in the presbytery so that they can understand firsthand how severe this disease can really be, what this virus can do. So thank you so much.
Thanks for the opportunity.
I'm going to move things along here and ask Dr. Williams and Dr. Watkins to unmute, and let's talk a little bit about what we were looking at with our issues of on the medical side of things, what we need to be thinking about, and
I'll be glad to talk, but to be upfront about it, I'm a PhD, not an MD, although I do research with at the MD Anderson Cancer Center. So,
and to be upfront with everybody, so that everybody knows, Dr. Watkins is my better half, and as you can see, she's the far better looking of the two of us. So just to have that disclaimer. So anyway, if y'all can tell us why we need to be looking at positivity rates, and also if anybody that is with us on Zoom, if you have a question, please feel free to put it in the chat box. And also make sure you're muted, please, if you're not speaking. So Dr. Williams, Dr. Watkins, let me have y'all talk about a little bit about what we need to be thinking about when it comes to positivity rates, case counts, all these things that we always hear, and how we need to look at focusing in on those when we start to look to reopen.
I will defer to the MD.
Well, good evening, everyone, and it is a pleasure to be with you. And I just have to make note that it is such a blessing to see my dear friend Manny Ruiz via Zoom, and to be here with all of you. Manny's testimony, and I've had the pleasure of knowing him, but before, during, and fortunately after this COVID event has really been a blessing. And it's just a reminder to each one of us that, there are individuals with unique, wonderful lives beyond the statistics that we hear on TV. And this year that we have had has been like no other, and has really affected us forever. And I am, as Ed would tell you, very much an optimist. I think that we are moving in the right direction. We aren't there yet. And there are lots of things to consider when moving forward with different phases of, and I know our Madison Square colleagues have said, phases of re-entry and things to consider. Many communities, and I have the pleasure of being a resident of San Antonio, have worked very hard to educate and update on what's going on in the community when it comes to everything from positivity rates to total number of cases, hospitalizations, et cetera. And those are important things to really follow and keep track of. Additionally, and fortunately, we are moving forward when it comes to vaccinations and vaccination rates as well. We have 3 that are now FDA approved under emergency use authorization. 2 that are what we call mRNA vaccination methodologies, where a piece of messenger RNA, which is the equivalent of our DNA, is in a lipid droplet, which is injected in the vaccine. and one that is an adenovirus, and that is the Johnson & Johnson single-dose vaccine. The two-dose vaccines are Moderna and Pfizer, respectively. And we are moving forward with vaccinations both in the community as well as in the state. We're not where we need to be, and I know there has been a lot of discussion around herd immunity, and different officials and different groups state it could be anywhere between 70 and 85% that we achieve of individuals achieving this herd immunity, whether by vaccination or by natural immunity. But the goal really, as much as we can, is to, of course, continue to mask up, social distance, vaccinate, and educate. And of course, maintaining great hand hygiene. So City of San Antonio or COSA.gov has a great website. I know Austin and other areas and the health departments have tried to work together with the state and the federal government to provide guidance on availability of vaccinations as well as positivity rates. And I know here in San Antonio, our target has been below 5%. For at least the last couple of weeks, and that the positivity rate is on a positive decline. What we have seen is that typically when there is an event or a gathering, if there is an increase in the positivity rates or positivity case or number of cases, that's approximately 2 weeks after. And then the hospitalizations are approximately 2 weeks after that. But we have seen, particularly over the last several weeks, fortunately, a very significant decline in both cases and positivity rates, as well as overall hospitalizations. And the very robust personal protective utilization, particularly masking, as well as the social distancing and the vaccinations are really having a positive effect, but we're not necessarily there yet. A lot of groups and a lot of experts, and I'll yield to Dr. Williams as well, will tell you that really the next 4 to 6 weeks are going to tell us what trajectory we're going to be on. And you probably ask, well, why is that? Well, we have folks coming back into schools. We have spring breakers. We've got individuals that want to travel. And I think that we are all kind of anxious to get out there and really to travel. And we've been at home quite a bit. So with that, and with some of the lifting and easing of restrictions, particularly of masking, that there, which is, again, once you see these events, there's typically a 2 to 4 week lag in positivity rates and hospitalizations. For those of us who are in healthcare or tracking this on a pretty close, regular basis, we're holding our breath a little bit. So really these next 4 weeks, 4 to 6 weeks are really going to tell us whether or not we'll have another, I don't know if it's necessarily going to be a surge, but definitely an uptick, or if we're going to continue to plateau, which is where we basically are at just under 200 hospitalized patients across the facilities here in San Antonio, for example, and continue to decline. So, as far as, and I'm looking at a couple of the questions in the chat, as positivity rates decline, one of the questions is what would be a reasonable positivity rate for churches as a threshold? I think that is a bit of a tough question. I know a lot of institutions have been following guidance of that 5% or below for a couple of weeks. But a lot of it also depends on a lot of factors within your church and your congregation. And I think that's that the CDC, and I believe I may have sent to Ed the link. The CDC has great guidance for communities of faith for considerations for reentry. And what the demographics of your congregation are one thing. Your physical plant is another, in HVAC systems, etc. When I've had the pleasure of working on the reentry team for Madison Square, we asked a couple of questions. What is worship? And that's important. The length of time, what do you mean by worship? Does that include activities such as communion and singing, etc.? Who is worshiping? And what are the demographics of your congregation? Is it a slightly older population, a population that may have a broader number of children who can be asymptomatic carriers, or a group that may have individuals that have other comorbidities? And where is worship? What is the plant? What does the plant look like? Is it a larger church, a smaller church? Is worship planned to be outside? So what is worship? Who's worshiping? And where is worship are three of the questions that we've identified, as important questions to answer when deciding to whether or not to re-enter and enter and come back to church. And I'm going to yield to Dr. Williams so he can provide some input.
No, I agree with everything you've said. There've been a couple of questions. I think Ed and I both provided the same link to the CDC guidance for communities of faith. So that's a good place to go to start. If you haven't read that yet, they bring up some of the points that were just brought up. One question about positivity rate and R value. They're not the same, but they kind of go together. Positivity rate is if randomly testing a number of people, how many people out of 1,000, I think it is, will come up positive. The R value is more of a statistical number of how fast the virus is spreading. You want that number to be below 1, which a value of 1 means if I have it, I give it to one other person. A greater than 1 means I'm giving it to more than one person, and then that leads to exponential growth. If the R value is below 1, that means it's exponentially going down. So we look for R values that are less than 1. A number of the things that were mentioned are very important. Looking at your sanctuary space, looking at your age of your membership. Our membership at First Pres Elgin is an older congregation members, and they are the ones that are always there Sundays. So we've had to not have services just to protect them from themselves, basically. So that's something to think about. The age of your AC, all of those things come into play in terms of spreading the virus around in the sanctuary. I'm trying to read and talk at the same time. Due to age, a number of our Presbyterian worship communities are likely have a higher rates of fully vaccinated people. Going ahead, so one of the things about the vaccines, they're good. They have a high effective rate, at least the Moderna and the Pfizer, and the Johnson & Johnson, I think is, was it 70%, something like that effective rate? Yeah, so they're all better than the flu vaccine, much higher than you get when you get the flu vaccine. But the evidence is not really there yet that they keep you from getting the disease. So you could be an asymptomatic carrier even if you've been vaccinated. So going to church unmasked in groups without, even though you've been vaccinated and maybe some of the other people there have, there's still the possibility of passing that virus on, which is why most of the guidance now is still social distance, keep your mask on, even if you've been vaccinated, because you don't want to give it to somebody who hasn't been vaccinated or who either by voluntarily not getting the vaccine or not having an opportunity to get it yet, or being around children who are then going to go to their grandparents' house later. There's all kinds of ways that these things get transmitted. So at this point, I agree with most of the guidance, which is stay masked, stay socially distanced, and just really don't change anything, even if you've gotten the vaccine.
Right. And I'm looking at the chat too. Thank you, Dr. Williams. So, we haven't talked about this, but it is important. There's been a lot of discussion about the variants, the UK variant, the Brazilian variant, the South African variant. We've got variants in the United States as well. And the 3 vaccines that are FDA approved under emergency use authorization have very high rates of effectiveness for prevention of hospitalization. But that being said, they're a bit less effective when it comes to these variants, particularly the UK and the South African variant. So it is because of those variants, and as Dr. Williams said, that you can be an asymptomatic carrier of the inaugural variant, that it's still important to mask, wash hands, social distance. There's been a lot of discussion about activities that are core to worship, including singing. And, what I would say is this, that with singing, there is aerosolization of particulate matter. And whether it's traveling 3 feet, 6 feet, etc., it still does, particularly for vulnerable populations, put individuals at risk. And although there is some literature that does vary, if one were to ask, is this something that would be prudent at this point in time, even though we're moving forward with vaccinations, it's probably not as prudent to sing, just like it wouldn't necessarily be as prudent to share food and foodstuffs, given that there are multiple variants of the virus out there, and that some of them, particularly the UK variant, are extremely, extremely contagious. Regarding full vaccination, what does that mean? It basically means that you complete the series, or if it's the single dose Johnson & Johnson / Janssen vaccine, get the vaccine plus a period of 14 days before someone reaches maximum vaccination. So say you've just had the Moderna vaccination, you're not fully vaccinated. You don't reach maximum efficacy of that vaccination until approximately 2 weeks after. But even beyond that, it's still important to mask up, wash hands, and social distance. So just in case you come in contact with a variant where it may be a bit less effective, and so that you are not an asymptomatic carrier. There is a question about masking and social distancing. Why would we not sing? There are different masks that have different levels of potential spread of droplets, and it's important that masks are also fitting properly and are covering both the nose and the face. Even with that, that's not 100%. Unfortunately, we have individuals that wear those mask gaiters that are probably the least effective. The 2-ply filter ones are effective. The most effective ones are the ones that are the hospital grade N95s, which we have tried to keep in the healthcare setting. even with those, there is still a risk. And in the healthcare setting, we do a lot with aerosolizing generating procedures, whether it's bronchoscopies or intubations, that even with those masks that provide significant protection and face shields, there is still the risk of getting the virus. So it is not 100%. The CDC has provided guidance regarding individuals that have been vaccinated and in contact, and that full vaccination, that in small groups, that there can be more interaction. But until we have, and that's something that you and your congregations would need to have a conversation about. Ultimately, this may happen anyway if there is a discussion regarding vaccine passports, etc. But until you know and you have the card, you're never going to know the vaccination status of your neighbor or individual. So that's always going to be up in the air. But even at this time when we have great vaccines, great efficacy, wonderful technology, it's still early on, and we have so many variants of this virus, and still a lot of work to do to get to the percentages that we need for the country really to be vaccinated.
Let me jump in because there are a couple of questions. What's the best argument to keep mask and distance in light of Abbott's doing away with the restrictions? Remember what Abbott did? He did away with the mandate. So there's not a mandate within Texas that you have to wear a mask. However, if you listen to what he said you should be following CDC guidelines, which is to mask. He was very, he emphasized that we need to be doing what's right for each other. And that's where we have to look at this. Are we doing what's right for our neighbor? And somebody else asked if we had a guideline document that can be tailored for reopening our church buildings. We're trying to figure this out just like everybody else. And everything changes so quickly that I think by the time we put together a guideline, it would probably have to be retrofitted almost immediately. So I will be sending out via Facebook and our newsletter some other resources for everybody to kind of look at and have in hand. Besides the CDC one I just put in, I also put in a one that we have from Christianity Today that is another good guideline for opening. So we've got a lot of things like that. And since we're kind of talking about how we're going to open, I want to bring in Jane and Phil into our discussion now and let them add to this. Now then, we've had the doctors in our discussion talking about the medical issues, but both of our doctors are also on the reentry teams for their churches. So, and let me see if I can get everybody on here the way I'm trying to. This isn't my normal job with presbytery meetings. Jane, have you unmuted? Can you talk to me so I can find you?
I'm up. I'm here. Can you find me?
You should be talking. There you are.
There I am. Hello.
We can see you and we can hear you. So,
yay.
Jane and Phil and Dr. Williams and Dr. Watkins have all been working on reentries for their congregations. Dr. Watkins and Phil are both at the same church. Larry is in Elgin, and Jane is at First Presbyterian Austin. So we're getting small churches, medium churches, larger churches, kind of getting a good mix here. So let's talk about some of the things that we need to think about. And probably the best way to handle all four of us, all four of you at the same time, is just kind of raise your hand when you're ready to say something with this. How are you going to handle healthy hygiene practices? Let's start with simple. How do we handle hygiene within our congregation when we start bringing everybody back? We've already talked about masks and the fact that everybody we still need to be thinking about wearing masks, and it still needs to be done. So beyond that, what do we need to do?
Well,
I-
go ahead. I just say in our document, which was written several months ago, so we probably need to relook at it as well. But hand cleaning stations at all entrances, no paper documents in the sanctuary, and cleaning immediately after the service or after everybody vacates would sanitize all the touchable surfaces, the back of the pews, things like that.
Yeah, I would echo that we're doing a lot of this, some of the same things. However, we are not back in worship. Ed, we reopened our school in the fall, and we have hand washing stations at every entrance. We have, instead of everybody entering the school at the same entrance, there's 5 different entrances, and the classes are not intermingling at all, not on the playground, not, during the school day. They're staying very confined to their teacher in their classroom. We're doing temperature checks when they enter. The parents aren't allowed into the building at all, just the children. They wash their hands when they come to the door and they enter. And we're planning when we can have children's ministry and youth ministry activities on site to parallel a lot of those procedures, to be able to have people enter in multiple places, to have hand washing stations everywhere. We have electrostatic cleaners and clean right after any activities. And we have changed, someone mentioned HVAC systems, and we have moved to MERV 13 filters in all of our HVAC units. So we're trying to do everything we can. We're prepared, but our decision is still to not worship in person indoors. We're launching our first outdoor services on Easter, and we'll do them on the first Sunday of every month until we decide to reopen for indoor services.
Phil, you had
I just wanted to respond to a question that I saw in the comments. When you say re-entry, first time to do face-to-face worship. And let me say, first of all, that everything that I've heard so far, I agree, but every church is different. Every congregation is different. Circumstances, budgets are different. All of that has to figure in. I would commend to you that at Madison Square, we've been communicating about being online exclusively for a full year now. Okay, our first communication was in May of 2020. And when we didn't really know at that point what we really meant by re-entry, we decided that we wanted to approach this in phases. But state governments and communities were talking about phases in very different ways, and phasing just didn't work from a communication perspective. So I heard a Presbyterian pastor, I believe a Presbyterian pastor, talk about being the church dispersed. And we adopted that language and then followed through by describing 4 stages of reentry. We are the church dispersed now. We then become the church emerging, the church gathering, and then finally the church reunited and adapting. And what we decided was that each of those phases would get us a little bit closer to how we normally worship, but not all at once. And we also said that if we are talking about a phased approach to reentry, we have to be willing to go backward as we so much want to go forward with reentry. We have to be willing to say things are not looking the way they should right now, so we need to take a step back. When we communicated with our congregation, we decided that the decisions of the reentry team needed to be theologically sound as well as medically sound. And we've got all of the great medical advice that is available to everyone out there, and we're using it to the best ways that we can. But we came up with a theologically based thesis, which stated that we chose to remain closed to in-person worship and gathering of any kind until all of our community can return in relative safety. So we knew relative safety was kind of an ambiguous term, but as we've progressed through this, we've started to be able to put a little bit more definition behind relative safety. And we look at the positivity rate, as Dr. Watkins has been saying, but we're also looking at the community rate of vaccination so that we can get a bigger picture about what relative safety means to us. It's not easy because, again, every church is different, every congregation is different.
So there have been several questions that have been popping up here in the comments in the chat. How often should a church worry about sanitizing? I mean, so if we've got 7 days between when the church is being used, do we need to worry about going in and sanitizing? I'll leave that to our experts.
Well,
we made the. I'm sorry.
No, go ahead. Go ahead, Larry.
Yeah, we made the decision that it couldn't hurt. So I'm thinking, I don't have my document in front of me, but it takes, if I remember right, 3+ days for the virus on hard surfaces. So, if you're only meeting in there once every 7 days, you may be okay. That's an average. So, some will last longer than the 3 days. Our philosophy was, why not clean it up after we moved out? It's a little Lysol on the back of the pews for the most part. It didn't hurt anything, and it would certainly, it may not help anything, but it's certainly worth the effort.
Yes, I agree with Dr. Williams, and the literature does state that the virus can stay on surfaces or fomites for about 3 days. And when you say come back to a facility, it's not just the sanctuary. It's the outbuildings. It's your office areas. It's your restrooms. It's your front doors and entrances. It's wherever potentially anyone can touch and potentially have that droplet material. So, though there may not be anyone in a specific area for a week, chances are that they're going to be someone is going to be in an adjacent area for less of a period of time. So it's important to get in the habit of continuing that routine disinfection, just, as a part in some churches and buildings. And I know we have it in healthcare. We have a routine checklist as a part of good infection control practices to clean, disinfect, check our HVAC systems, make sure that we have personal protective equipment, and also continue to mask and social distance. This is the new normal. And whether it's where we're worshiping or where we're living, eating, sleeping, or other activities, disinfection is a part of life.
There's a question about childcare, and I know for the nursery, and I know that's something, Jane, you probably have a handle on, but it's also brings up a couple of aspects. One that I was reading today that I thought, that's an interesting part of that, because a nursery is going to be a choke point. Everybody's going to be lining up to get to their baby as quick as they can. And the other thing that was mentioned in an article I was reading today was hallways can be very narrow in some of our churches. And so if there's a bench sitting there, then people are going to be brushing up against each other, coming in contact. So what are y'all thinking about as far as the choke points? I know Madison Square has a couple of different exits, so they can kind of move people in one door and out the other, and a couple of ways in and out. With First Presbyterian, I know y'all get there are a couple of exits that go straight outside to the road, but I don't think anybody getting run over. And so there's the choke point of coming in and out. Elgin, I don't know as well. So how are y'all looking to alleviate those choke points that most of our churches are going to have somewhere in the building, and especially with nursery care? Go ahead, Jane.
Well, I'm actually going to give you kind of a non-answer because at this point in time, even as we worship outside, we're requiring that children stay with their family unit, that worship is an intergenerational family worship decision, and that we will not have our nursery open. We feel, I mean, up to a certain age, it's just impossible to have masked kids. As we re-enter into the fall, we've talked about being able to do entry and allow perhaps small groups, dividing our Sunday school classes smaller and having different entry points for children who are already in the school systems and used to wearing masks. So that's children usually ages 5 and above. But we're not willing to take the risk of putting all those kids in a room that aren't vaccinated, that could be carriers, that will then be picked up by, we don't really know the situation of each family. So we're asking for social distancing and for people to stay together in their family unit as we start. So that's kind of a non-answer for you.
Well, Elgin is, we're fortunate we have multiple entrances and exits so that we can have a one-way system. You can come in one door and then we'll exit by another one for both the sanctuary and the education building. I don't know if I was clear earlier, we are not meeting in person. We are holding once a month parking lot type services. So we have not made the decision yet to bring everybody back in.
Phil and Lynette, anything as far as, what's been talked about at Madison Square as far as moving people around within the sanctuary, or has it been decided, I mean, especially with First or some of the other congregations, are you going to try and dismiss by pews, by rows, so that people are, leaving in a more methodical nature?
So I'm going to deliver a non-answer as well. And the non-answer is that we're not there yet. We have started to talk around some of the physical issues around the building and how to move people. But we are committed to being in the dispersed phase of a church, at least through the end, I believe, through the end of April. Mm-hmm. And when we start thinking about emerging, now's a good time to start. Actually, we need to engage with worship committee and our physical building committees to make sure that we do things that are logical, that are sound, and that are realistic within the parameters of what our structures will allow. So we are going to engage our other groups from session to help us make those decisions. But we have just started to talk about, is the HVAC system adequate enough? And it's not. Can we open doors? And we've said that really doesn't work very well. We can't open windows at Madison Square. So we've still got that to look to progress through as we get through some of this reentry.
Now, here's a question kind of for all of y'all. In thinking about as we get to the point of reentry, how do we make sure that we're not letting somebody in that's sick? And maybe I'll leave that to start out with the doctors on how to identify that, and then maybe Jane and Phil can fill that in as to how they've looked at it, if they have yet.
Well, you can't 100% of the time. That's the issue, because there are asymptomatic carriers of the virus, and any one of us on this Zoom chat, myself included, may be an asymptomatic carrier. And, we talk about, masking and social distancing and other things. We do that, and healthcare experts communicate that because we have to assume that our colleagues and friends are positive until proven otherwise. Okay. So in that vein, it's important, vaccinated or not, that still have to mask. We still have to social distance. We still have to wash hands. We still have to disinfect and take all of the precautions that we need to take in order to protect ourselves and each other. We can distance, we can temperature screen, there are a whole host of things, but that's the sneaky part about this virus. It has been able to grow and adapt and change. And while we've taken great strides in vaccinations and treatments, and you've heard a lot of that tonight, there's still much yet to be done, and we're not ahead of it. So that's why it's important to continue to take all of these measures, vaccinated or not.
I love the discussions that are going on in the chat room too. So I appreciate that. Jane or Phil?
I don't think you can't keep the sick people out, because usually they don't even know themselves. If they were sick, they'd probably be home. Our session had a long discussion about using, temperature checks and stuff when people come back. That's sort of some people were willing, some people aren't. So, I mean, I think we have to trust people to ethically do the right thing and have to have really strict guidelines on what we expect from them. But I don't see how we can prevent it.
Yeah.
I
There's,
know
go ahead.
Sorry,
I
there
know
was
that
an
one of the things
question earlier on the chat, and it kind of pointing to some of the more recent comments about ethically asking people if they've been vaccinated or not. That was something we avoided in our reopening plan. It's actually something that MD Anderson doesn't even ask their employees. There's no tracking mechanism. For our flu vaccines, we get a little button to where it proves we were vaccinated. But for this, they've decided that we're just going to treat everybody, like Dr. Watkins said, everybody's infected. You wear your mask, you wear your social distance, and you do the hygiene. They're not going to ask whether you've been vaccinated or not. And it's a tough question, but I don't think it will put you in a good position to be asking that of your congregants.
And it's early, but I suspect that as time goes on, particularly as vaccines become FDA approved and the emergency use authorization is removed, as we have more data and more time, that like the flu vaccine and like other vaccines, that it will be more acceptable to potentially to ask. And I know that's a big ethical and medical legal question as well. And it may come down to the fact that individuals may not be able to do the activities that they want to do, like travel, without being able to show vaccination status. And in some countries and in some industries, we're starting to hear about that. And there was a question about flu. Flu is much lower this year than it is in previous years by a factor of 5 to 10x of what it normally is. Why? Because we're wearing a mask, and we're washing our hands, and we're social distancing, and we're not going anywhere. We're seeing that in hospitals. We're seeing that in adults and in children. But there is, and I'd be remiss if I didn't talk about this, that while there is still a barrier to understanding COVID-19 and its severity, there's also a barrier to vaccine and a significant amount of vaccine hesitancy out there. So whether you're in a rural location, urban location, or somewhere in between, a lot of the work that we are doing, particularly in healthcare, is education around vaccine hesitancy, and understanding and being respectful of some of the deep distrust that has historically been out there regarding vaccines. I think the key is to acknowledge it, to educate, and to communicate with compassion in order to really move forward the vaccination effort. It's through vaccines and all of these other initiatives that we're ultimately going to be able to get ahead and come together and reunite again.
Let me jump in here because there's some questions I want us to try and get to and move things along, because y'all, we could go on this all day long and I don't want to keep everybody tied up for too long. Mitigation, the question was asked, mitigation is not perfect. Is a 90% solution good enough? Let me kind of put that in there. Are you willing to sacrifice 10% of your friends? A 90% solution in this case means that you lose 10% of your friends. So I don't think that falls unto our commandment of love thy neighbor. And how do we convince the rural church of the threat and the seriousness of this virus? I would suggest run for them Manny talking about what he's been through. And I think if that doesn't convince them, then nothing will as to how deadly this disease is. And I don't know if Sally has anything theologically she would like to add to that or not. But I think that is, this is all about love your neighbor and caring for one another. And 10% is still too high. If you're looking at if 90% is good enough, we still have to maintain vigilance at this point. And when it comes to the vaccinated and the unvaccinated, I was reading a wonderful article today about that basically looked at it theologically and said, would Jesus have excluded somebody? And the answer is no. And so how do you worship? That's going to be up to your congregation to figure out when you can come together as a whole, as a body. Let's see. Now then, there were a couple of things. What are you, for Phil and Jane, as you, and Jane, y'all have your school going. Have y'all changed anything with your maintenance procedures?
Absolutely. So we obviously the hygiene aspect was stepped up greatly. We're cleaning when the kids go out on the playground, and then at the end of the day, we purchased electrostatic cleaners. So after we actually surface clean, then they do they spray the whole place with that electrostatic cleaner. We replaced all the filters in the building with the highest level MERV 13 filters. And then I mentioned earlier, we have hand washing stations and we don't allow the parents to come into the building. So we definitely changed it. We changed our classroom structure, which used to be like 2 teachers to every 12 to 15 kids. And now it's 1 teacher to a max of 8 children, and the classes never commingle. That's what we've been doing this year. The plan for the fall is hopefully to reopen with a slightly more normal structure, but to continue the hygiene procedures. So we're hoping that we can go back to having a few more kids, because when we lowered the numbers, we were sort of bleeding money financially. But the parents that are back have been ready to be back. They've been incredibly cooperative, and we did have 1 case of COVID that was a parent, not one of the kids, and that 1 classroom closed down for 2 weeks. But other than that, we've maintained really strict protocols, and we haven't had any serious illnesses. So.
And if I may, I know there's a question here, and this has been a wonderful session, and hopefully informative. And please, if anyone has any additional questions, Ed, you can feel free to send them my contact information. I'd be happy to reach out. One of the questions that came up was about discussion about vaccination status. And I agree, I think that's going to be difficult. And at this point in time, unless it's volunteered, it's still protected health information. So, it would be incredibly tough, and those that are, addressing it are really at the sharp tip of the spear right now when it comes to those sorts of disclosures. So it does have to be on the honor system. But as I mentioned before, when you make these decisions to come together, as Phil said, each congregation is different. Each church is different. And there are lots of things that have to be taken into account. And each community is a bit different when it comes to positivity rates and others. And you have to take all of that into consideration. And as I mentioned before, it comes back to, what do you mean about, what is worship? Who's worshiping? And where are you worshiping? Taking that into consideration in the resources that you have, and building from there. There's not going to be a silver bullet, but it will be important to understand how you want to worship, what resources you have, and what the environment and the community you live in is like, particularly looking at positivity rates as well as vaccination rates.
Have to unmute me. Would you suggest any kind of special signage as our congregations start to open? I mean, we see all the, stay 6 feet apart and things like that. How do we make sure that happens, and how do we communicate things that we need to think about as people are going about worship in the church? I mean, I know a lot of places are taking out the hymnals and things of that nature. What about, how are you going to organize seating and, keeping that distance?
Well, I think CDC, and you put the link in there, Ed, has a lot of great guidance for communities of faith. And it talks about everything from preparation and mitigation to signage, and also dealing with the issue with what if somebody does become positive, and that is communicated. So, that link, and starting with cdc.gov, I think it's /communities of faith, is very, very helpful, and going from there. A lot of literature, Christianity Today, other sites, Johns Hopkins has a lot of helpful information, as well as Mayo Clinic. I've been very pleasantly surprised that a lot of our major newspapers are publishing a lot about COVID-19 in different communities, and has been very, very informative. So there is a lot out there. But if I have a question, the first place I go is cdc.gov. And then your cities and counties also have wonderful, wonderful information. Your public health officials are working day and night to provide this information. So whether it's COSA.gov for City of San Antonio, I know Austin Public Health has a lot. The counties in the Valley, Cameron County is doing quite a bit. So go to your city and county websites as well.
We've kind of hit beyond our hour point here, so I want to wrap things up really quick, and just kind of go over some of the things we've talked about, just to instill this with everybody. We still need to wear a mask, even though we've been vaccinated, even though we're staying distanced. We still need to wear a mask, and yes, we need to stay distanced. Even if we're vaccinated, we still don't need to sing, because we don't know if you're still a carrier, even if you've been vaccinated. So we still need to make sure that, we're not singing and we're wearing our masks. And I know that's hard for all of us who are Presbyterian because we all like to sing. But that's kind of where we are. And I think for those who have the ability and the technology within their congregation, continue to put your choirs up on screens and let them sing, via a video, as opposed to putting them into that kind of situation. You're not immune if you've had the vaccination, especially with the variants that are coming around. It's still possible you can catch this again, but if you've been vaccinated, it shouldn't be as severe. You can find the numbers for your areas through your local health departments and your county health departments that can help you understand where the numbers are within your community. That's the reason we can't tell you you can open, is because each one of our communities is different. And we need to understand that. There's no one size that's going to fit all with reopening. We all want to open. We all need to do it safely. We all need to think about how we're going to do this in a safe way to protect not only ourselves, but our neighbors, and show our love of Christ to everyone we meet. I want to thank everyone for joining us. And if I can impose on the wonderful Sally Watson to close us out, I would love to.
All right, friends, let's pause for a moment of prayer. God, thank you. Thank you for the way that you lead us, the way you encourage us, the community that you give us, even through virtual means. As we make plans to regather again after we have been dispersed, help us to be wise, to be caring, and to reflect your love. And now as we go about the rest of our day, even though it's a short time left, help us to rest well, to know that we are held in your care. In Jesus' name we ask it. Amen.
Thank you, everybody. Have a wonderful night, and blessings on reopening.